in the working population globally. It's estimated that the number of people with diabetes will increase to 642 million by 2040. That is a pandemic, significantly so. When you think about the numbers of COVID right now, it tells you quite blatantly that that is a pandemic, and this is there's a peak, but we're just looking at the tip of the iceberg at the moment. Now, with diabetes, what exactly happens? With elevated glucose levels in the serum and time, so with duration over time, you get damage to the basement membranes of the capillaries, you get endothelial cell damage, and you also get the platelets being, stickiness being increased. All of that added together cause occlusion of capillaries and leakage of the venular end of the capillaries. And overall, you get damage to the microvasculature, which can lead to either diabetic macular edema, which is the most common visual loss, cause of visual loss in diabetic retinopathy, or capillary non-perfusion, which then proceeds to cause proliferative diabetic retinopathy, which is a significant cause of visual loss, or diabetic macular ischemia, which we all know happens. We all can identify on fluorescein angiography, but there's no treatment for diabetic macular ischemia at the present time. So the prevalence of diabetic retinopathy ranges from 30 to 45% in patients with diabetes, and 1 in 10 have vision-threatening disease. With the projected increase in the incidence of diabetic macular edema, you can expect that, diabetes mellitus, you can expect that diabetic retinopathy will inevitably increase over the coming years. So how do we normally diagnose diabetic retinopathy? Well, typically it's divided broadly into non-proliferative and proliferative diabetic retinopathy. The main sight-threatening options, as I mentioned, is diabetic macular edema, diabetic macular ischemia, and proliferative diabetic retinopathy. And the current standard for assessing diabetic retinopathy is fundus photography and fluorescein angiography. In many countries across the world, we have national screening programs for diabetic retinopathy. In the UK, where I practice, in England, certainly, there is the diabetic eye screening program, which is a national program. It's slightly different in Scotland, but also there is a screening program. And typically, every adult over 18 diagnosed with diabetes is referred into the screening program and has annual photography. And then, and this is graded by non-ophthalmologists, who then, using features-based grading standards, refer patients into hospital when they're discovered to have pre-specified lesions on their photography. So basically, we depend from a screening perspective on fundus photography, and when they come into hospital, in terms of treatment, we are heavily dependent on OCT and fluorescein angiography. Now, fluorescein angiography, I say 60 years of glory because in 1961, 2 medical students described this method of visualizing the human retinal vasculature, and in particular, they defined neovascularization on fluorescein. Since then, it's become a staple of practice of medical retina across the world. So this is an image. I haven't got a pointer. I don't know if you can see my cursor. The bright areas there that I'm pointing at are areas of neovascularization, all right? And what fluorescein does is it doesn't just allow you to see the abnormal blood vessels, the neovascularization, it also allows you to see the flow through them. So you can see that they're there and that they're leaking, they're active. It goes beyond that though, because it shows you all the features of diabetic retinopathy, from mild, like microaneurysms, to ermers, to venous beading, to venous reduplication. But in particular, we do this to help us identify significant ischemia, because many of us will laser patients with severe non-proliferative diabetic retinopathy or patients with proliferative diabetic retinopathy. So it's our staple for defining patients who are at risk of visual loss, and diabetic medical retina practice is really dependent on this particular modality. However, if you remember from your textbooks in med school, the retina isn't actually a 2D feature, particularly the vasculature. So this is a picture from a medical textbook looking at the depth resolved image through the retina. And I'm pointing at the retinal pigment epithelium there, which is orange. And at the top there, right at the top, is an inner limiting membrane. And you can see through the cross-section of the retina, there is a superficial capillary network. Then below that is a deep capillary network. And even there's an intermediate capillary network that has been described as well. So whilst the fluorescein angiogram just shows you the superficial network, which is this bit, sorry, where's my cursor? This bit there, there is much more to see beneath that the fluorescein does not allow you to see. The other limitation of fluorescein angiography is that it cannot separately visualize, as I said, the intraretinal structures. You can't see the deeper retinal capillaries. It's limited in how it visualizes choroidal vasculature, which is why we often use ICG when we need to look at the choroid. And also, when the leakage is useful, because you know a particular lesion is active, but the leakage also limits microvasculature alterations because you get fluorescein all over the place, so you can't actually see the fine details sometimes. And additionally, there's a risk of allergic reactions and, although rare, anaphylaxis. So in the UK and possibly globally, if you're going to have a practice where you have fluorescein angiography, you usually have to have a crash trolley nearby, nurses trained in resuscitation, a doctor nearby. It's not for the faint-hearted, so to speak. You need a highly skilled photographer, and it also takes some time. Now, OCT angiography, this is what my talk is about, but I thought it was important to lay a foundation of what we're currently doing now, what is gold standard now, and also, hopefully, you can see what this modality can bring. It basically uses motion contrast to produce higher resolution angiographic images. So the images look like fluorescein angiography images. However, there's a distinct difference. It uses OCT to actually, when you take sequential OCTs in the same cross-sectional area. So you basically have high-speed OCT in the same area, and because axial bulk flow of the patient's eye is controlled for, the patient is fixating, what happens is any other movement in the eye is deemed to be from the erythrocytes, so some blood cells. So it's basically detecting, it's calculating flow. So you're not actually seeing blood flow, you're actually seeing a correlation or calculation of flow based on what we believe has happened to the erythrocytes as you've repeatedly OCT'd in a specific region, which is why it needs to be very high speed, much higher speed than our usual OCTs. And it's a larger image than you would in terms of space, surface space or size compared to regular OCT. So what is the advantage of this modality? It's highly detailed. It's depth resolved. As I say, you can actually look beneath the surface. It's cross-sectional. It gives you this angiographic representation, just like fluorescein, without the dye. So it's non-invasive and it's quick. And there's no risk of allergy, all right? It's done in the outpatient clinic. You can teach almost anybody to do it. Now, what benefit does it bring to diabetes? Well, microaneurysms, which are typically the earliest signs of diabetic retinopathy, are well observed on fundus photography and on fluorescein. OCT allows you to actually visualize them. I don't know if you can see the bright spot there with the arrow A, labeled A. That's a microaneurysm on an OCTA image. However, and that way you can actually see not just that they're there, but also what level they are. And current studies have shown, OCTA studies have shown, these microaneurysms that we just assume from fluorescein are just there superficially. There are actually more of them in the deep vascular plexus than they are in the superficial plexus. However, they're not always visible on OCTA because, as you can imagine, since OCTA depends on repeated scans of the same area to and uses the change to detect flow, if the flow is very slow, as can happen in many microaneurysms, it doesn't detect flow, so it doesn't detect that microaneurysm. So it's not always, not all the microaneurysms you can see on fluorescein are visible on OCTA. Moving on from there, when we move on from mild proliferative diabetic retinopathy to moderate and severe, then you start to come into a position where I think OCTA will come into its own. It's still in research, but I think it's coming into its own in this area. Because certainly in the UK, when we look at diabetic retinopathy and referrals, patients with R1, so we grade them as R1, R grades and M grades. There's R1, which is mild proliferative, non-proliferative diabetic retinopathy. There is R2, which is moderate to severe. And then there's R3, which is severe. And the current guidelines say that R2 patients are referred into hospital. Obviously, R3 are because they need treatment. And the thinking behind the R2 patients being referred is that they might come to need treatment. Now, the R2 box is quite large because all you need to be R2 is an ERMA, venous beading, features that don't necessarily mean that you're likely to progress very soon to proliferative diabetic retinopathy. So then if you use the ETDRS grading, severe NPDR is defined as presence of 4 quadrants of retinal hemorrhages, 2 quadrants of venous beading, and 1 quadrant of ERMA. So the 4-to-1. Very severe would be if you have the presence of at least 2 of these features. What the significant unmet need is how to delineate which patients in the non-proliferative diabetic retinopathy group are most likely or at imminent risk of progressing to visual loss or sight-threatening visual loss lesions. And OCTA has been used to try to help in that area. So this is an image from the England, the UK retinopathies grading. This is what graders, one of the examples graders have. And that there is a blood hemorrhage. And if you have 4 quadrants of that, then you're deemed to be, that's a feature of R2, and then you're referred into hospital. Similarly, if you have an ERMA, which is pointed to there, it can be quite difficult to find or to identify, then again, you're referred into hospital. Now, with ERMA, as I said, that can be quite difficult to detect on, but also you're not allowed, and might not allowed to do that, because if you do that in grading, you'll end up flooded with patients who are barely something there. However, we know that ERMAs, particularly when there's a lot of them, have patients with those eyes have a high progression, a high risk of progressing to proliferative diabetic retinopathy. So a study was conducted to looking at OCTA in ERMAs and in proliferative diabetic retinopathy, and OCTA was able to detect a higher rate of ERMAs compared to color photography, which is what we would normally use in our screening programs. They also looked at patients before PRP and after PRP, and they looked at ERMAs in these patients and capillary non-perfusion. So you can see this particular eye, right, before PRP, and then you can see what happens. So that's the same eye but zoomed in, and then you can see what happens after PRP. OCTA allows you to see that there is remodeling and revascularization. If you wanted to show that with fluorescein, you'd have to put the patient through multiple dye injections. This allows you to do it in a non-invasive fashion. It also allows you to look at how ERMAs behave and vascular lesions behave. So these are examples of sort of tufts with ERMAs before PRP and after PRP. And you can see that it's remodeling and the tufts sort of start regressing after 3 months. What about new vessels with OCTA? Well, if they're left untreated, we know that new vessels result in hemorrhage and traction and blindness.
Hello? Yes? Hello?
Hi. Can you hear that? Can you hear someone else talking? Hi, I can't hear you. You're mute.
Please go ahead, ma'am.
Okay,
I can hear
you. Okay, sorry. There was an interruption. A conversation was happening. Okay, all right. So where was I? Yes, new vessels. If left untreated, they cause blindness through hemorrhage and traction. They can be detected non-invasively with OCTA by looking at flow above the internal limiting membrane. And you can even detect subtle neovascularization as well, as you can imagine, because all you're looking for is flow with the vascular flow pattern overlay on the OCTA. So this is in research. This isn't available at the moment commercially, because commercially the size of OCTA that's available is 3x3, which is basically around the macula, or 6x6. And Zeiss have current equipment that is 12x12, which is essentially the whole arcade. But in research settings, you can have montages made, wide field angiography, and the blue areas that you can see are areas of non-perfusion. And in A, don't know if you can see my cursor. Yeah, in A, this is before PRP, and in B, this is after PRP. So you can see there's less blue. So that shows you that there is less non-perfusion after PRP. But interestingly, what we didn't know before that we now know with OCTA is that the vascular perfusion at the macula looks like it does improve after PRP as well. So there seems to be a redistribution that happens after PRP, which is still under investigation. But again, this tool allows us to do this non-invasively and look at the effects on the microvasculature of all the interventions we're all happily doing all the time, PRP, macular laser, and so on, and injections. Now, all of this seem very subjective. So obviously there's a need for quantification, which should allow us to be able to compare changes or features on an OCTA across images. So many researchers have looked at quantifying, creating metrics, quantification metrics on OCTA. So for instance, we know that in diabetic retinopathy, there is an enlargement of the FAS, which is the foveal avascular zone, due to loss of capillaries at the macula. Well, various metrics have been used to try to measure the FAS so that we can see what happens to the FAS with OCTA more intimately than we could have done with FFA. So I hope you can see this image. This is the image of the FAS with OCTA. If you look normally, you know there's a ring, there's an internal ring, but if you look temporal and the temporal side, you can see that that ring seems to be sort of broken beyond that. So there's larger spaces, which is where you've got capillary non-perfusion. And so there's clearly less blood vessels around that area. Now, before you get to the point where you have complete FAS enlargement, where you have significant capillary dropout, you usually have this enlargement of spaces around the FAS. So what researchers have done is they've used software and mathematical techniques to process the images from OCTA so that first you can remove the noise, then next you binarize it. So you've got, you separate the vessel, you almost skeletonize it. So you've got the vessels and the spaces, and then using that, you can calculate metrics like vessel density, FAS circularity, FAS area, FAS parameter, things like that in millimeters squared and in millimeters. And these numbers are then used, can then be used, or these features can then be used to compare various images. So for instance, the vessel density, if you have an image, an OCTA image, right? You would normally have vessels and then you would have the image, the total measured area. So the vessel density will be the proportion in pixels of the picture that is taken up by the blood vessels. And then that tells you how many, how much vascularity you have in that area. Obviously, you can then extrapolate that in a patient who's losing capillaries, they will have lower vascular vessel density than in someone who has no needs, no disease that's causing them to lose vessels. Same with vessel length density. That's now looking at the length, and combined together, that has higher sensitivity in measuring differences in vascular density. Another measure is fractal dimension, and that's looking at the complexity of the vasculature branching. So basically looking at how they actually branch out. And again, we know that branching or the geometry of vessels change with damage and with progression in diabetic retinopathy. So there's now been described at least 13 metrics. Many of them, small studies have been shown that show either they are predictive of changes in diabetic retinopathy, others are not. So there's clearly more studies that need to be done. But I'm just going to highlight some important ones. Cal et al. In 2018, they looked at 71 diabetic eyes, but with no diabetic retinopathy, and 67 healthy controls. And they showed that the vascular density was reduced already in patients, in the diabetic patients, in the superficial plexus and in the deep plexus, and even in the choriocapillaris. And this was not correlated to the HbA1c or the serum creatinine. So that tells us that even before you develop diabetic retinopathy, hyperglycemia is causing damage to the blood vessels on a microvascular level. And we didn't know that before OCTA. And this is a summary of 3 other slightly bigger or well-powered studies. No study at the moment is level 1, so there's no randomized control trial at the moment looking at OCTA in diabetic retinopathy. So let's say that this is early stage research. However, we have pointers, we have cross-sectional studies. So for instance, Abd et al. In 2019, they used the Cyrus OCTA, 50 diabetic eyes, 50 controls. Again, they showed the vessel density was lower in the diabetic eyes, and the FAS area and the perimeter were larger. Same has been confirmed in other studies. And then moving on to the severity of diabetic retinopathy, quite a lot of researchers have shown that there's enlarged FAS area, reduced FAS circularity, lower vessel density as the severity of diabetic retinopathy increases. But these are, again, cohort studies, not longitudinal studies. So they're comparing, you have maybe 80 patients where 20 are R1, 20 are R2, 20 are R3, and then they compare them across and see, and then they compare the metrics, and they found that there is a significant difference in this metrics across those groups. Then diabetic retinopathy, from using OCTA, who's going to progress and how soon they are to progress. Well, at the moment, there's one longitudinal study that's very small. If we use talking about how there's a difference across the rates, then you can imagine that quantitative OCT analysis may be able to identify diabetic individuals at risk of progressing as an independent feature. What about diabetic macular edema? Well, the problem with diabetic macular edema is that the fluid in the eye interferes with the signals from the OCTA. So oftentimes the images are poor. In my clinic, I see a lot of diabetics and we OCTA most of them. It is very frustrating in patients with diabetic macular edema because there's a lot of backscatter. The fluid prevents you from being able to segment the images properly. You can't even, because you can't segment it accurately, the next time they come, you can't actually have, the image isn't tracked to the same, the vessels are not tracked, they're not marked, so you're not scanning the same position. And also, the flow is affected by the fluid because the fluid probably presses on the vessels underlying it. So overall, it's difficult at the moment, and that is an area that is actively being researched to find algorithms that can account for the fluid so that we can actually study DMO in detail. But what was interesting, Sun et al. In 2019, they investigated patients with diabetes before they had DMO and longitudinally looked at a 2-year follow-up. And using OCTA, they were able to show that the vessel density in the superficial plexus was predictive of which patients would develop DMO. These are small studies. All these studies are 50 eyes, 49 eyes, so they're quite small, but they're signals that this technology may have the answer to some of the questions that are outstanding in diabetes. Again, with the choroid, we know the choroid and the choriocapillaris specifically is affected in diabetes, but the findings at the moment in small studies are discordant, so more needs to be done in that area. What I find also exciting is systemic diseases. Anyone that manages diabetes knows that it's not just an eye disease, it's a disease that affects different parts of the body. And you know, as I say to my patients, as goes the eye, goes the kidney, goes the brain, goes really, you know, even the major vessels. So it's quite important to think about diabetes holistically. OCTA, again, can help us in that arena because, for instance, the study was done with 184 patients with type 2 diabetes and they cross-sectionally had OCTA, and the vascular density was independently able to predict the ones that had chronic kidney disease and the severity. So this is, and we know that there's already research going on in using the same modality, but in hypertension, in cardiovascular disease, in foot ulcers. So again, this is an avenue to investigate the microvasculature and to use it to predict not just progression of diabetic retinopathy, not just predict when it's going to come on, but also the effect on other organs in the body of a diabetic. But OCT has technical issues. There's projection artifacts, which is basically where you're taking a picture, but the layers on the top, the superficial layers, interfere with the images on the bottom layer and project beneath it. There are blink errors. There are banding artifacts. There are quite a few artifacts, and this is why I would say this technology is not yet prime time, but these are artifacts that are constantly being worked on to improve the algorithm to be able to remove them so that we can see purely what this image is what this technique is trying to tell us. And the worst part is that these artifacts tend to be in eyes with pathology. So you can take beautiful pictures of the macula in patients with no disease. Beautiful pictures, describe all their plexuses and everything, but we need it in patients with disease. So definitely there needs to be a refinement of the algorithm to improve the quality of the images we get from them. So those are some of the practical issues. There are other practical issues. Patients with cataract, the hazing media means you lose signal. In extramacular diseases, you can't see it because the field is too small. It's typically, 6x6 is the one we have. We have the Heidelberg Spectralis, but I know the Zeiss do up to 12x12, but still with diabetic retinopathy, the entire retina is involved. And the larger views are not yet commercially available. So I wanted to end just basically talking about two things. One is a case study of a patient I saw recently in my clinic, 48-year-old type 1 diabetic. I'm not sure how bad the diabetic eyes you see in Nigeria are, but where in my part of London, they are epic. That's the word we use because the control here can be quite poor. We have a multi-ethnic population with a high deprivation index. So this gentleman presented to us, referred from the eye screening program, R3A in his right eye. R3A, remember, is proliferative diabetic retinopathy. R2 in his left eye, which is pre-proliferative. And in his vision in his right eye was 618, in his left is 67.5. He had had poor glycemic control for years, alcohol misuse, but was trying to get his life back together. He said that he had reduced his smoking from 20 a day to 3 a day, and he had a left foot ulcer that it was under the podiatrist for. And this is what the image from that we took showed, the fundus photograph. And I don't know if you can see all these deep blood hemorrhages. They are indicative of ischemia, right? And there's all the cotton wool spots as well. The veins are dilated, die. And this picture, and thinking fluorescein comes once a week, and this was not his day. So we thought, well, we have the OCTA, which we purchased with research funds. So why don't we, the reason we wanted to see mostly was to look at the macular. If we PR gentleman and he develops reduced vision, he probably will say what we've done is what has made him worse. So it's important for us to get a baseline of what's happening at his macula to see why his vision is that bad. Because you can have all this neovascularization but still have good vision. So this was OCT done in our clinic. And this is his left eye, I believe. And you can see that the foveal ring is broken. And you can see there's increased spaces in between the vessels, and here too. And this is the deep, so that's the superficial layer, and this is the deep layer, similarly also affected, right? But one thing I want you to notice is this gray blob, because that's the fluid from the macular edema he's got, sort of further blurring the image there. However, you can still appreciate that the FAS is bigger than it would ideally be expected to be. And this is his left arm, it's elongated, there's significant capillary non-perfusion there. And this, the deep layer, it's even bigger. And that's the other thing OCT has shown us, that the deep capillaries tends to be affected more significantly than the superficial capillary plexus. So what am I doing about this? Well, we currently, my group and I, so our diabetic research group, have currently written a protocol that has just been submitted to BMJ for to look at a longitudinal study of 300 patients with R2 and follow them up every 4 months with fundus photos, HbA1c, checking on their medical history, but also repeating OCTA every 4 months over 2 years. And our research question really are any of these metrics predictable in a significantly powered way to predict which patients will progress at a faster rate? And the idea behind this is to see if the OCTA can be incorporated into screening programs to help reduce the number of patients that need hospital referral, but also the interval of reviews even in the screening program. You can imagine that that will save money, but also it might mean that in regions where using fluorescein angiogram is a patient, either from expertise from the photographer, from interpretation or cost, then OCTA could be a modality that can bridge the gap in those areas and not just do what FFA does, but actually add more information. So these are the research questions that I think are still outstanding. Can OCTA predict patients more likely to develop DMO? There's a suggestion it can, but we need larger studies. Can OCTA detect patients more likely to develop non-ocular microvascular complications like microalbuminuria, diabetic nephropathy, foot ulcers? So these are things that are yet to be done, but absolutely this modality can help us do that. But we obviously need to refine the modality and improve the algorithms so that it can go prime time. Thank you very much. My summary is that OCTA is here to stay and everybody is invited to play. Thank you.
Thank you very much. That's an excellent overview of the use of OCT in diabetic retinopathy.